Okay.
A very good afternoon to one and all present here. We welcome you to the 6th session of Virtual PedoRare 3.0, a virtual rapid revision summit to achieve perfection, organized by the Indian Society of Periodontics and Preventive Dentistry, hosted by KSI Institute of Dental Science and Research, Tiruchengodu, Tamil Nadu. We welcome all the students for this particular 6th session on traumatic dental injuries. We have our own IK Pandit sir and my good friend Dr. Viraj as the moderators for this particular session. And we have 3 speakers for the day, Dr. Nilesh Rathi, Dr. Faisal, and Dr. Rupesh. I take it as my privilege to introduce the first moderator, Dr. Pandit sir.
Hi, hello.
Yes, sir. So I'm going to introduce you, sir.
Yeah, sure. Yes, just introduce me very briefly.
Yes, sir.
So that we should save some time also.
Yes, sir. Yes, sir. I think I said it's our own Pandit, sir. I think that should take care of everything, sir, from north to south of India. I think it's always our Pandit, sir. So Pandit, sir is currently the principal and head of the department at DAV Dental College, Yamunanagar. He's been our past president and the secretary general of ISPPD. He has more than 200 publications and he has more than 200 guest lectures in different forums. He completed both his BDS and MDS from King George Medical College, Lucknow. To keep it short, he is one of our moderators for the traumatic dental injury session. Right? Thank you and welcome, sir.
Thank you very much. First of all, it is a great privilege that ISPPD is doing this series of programs for to enrich the knowledge of our young students who are pursuing pedo from various parts of India, and it is a great deed ISPPD head office is doing. But honestly speaking, this program, which was quickly given to Saraj, you and to Geeta Priya, and I know that it was very short period of time, because when we were deciding who is going to host, I think we just chose you before you could say yes. But then you are handling it in such a nice way, and everything is going on time. It is really a credit to you. I don't know how manpower you are arranging it through the manpower and all those things, but each one of us is really appreciating your and your team members' efforts to make it really possible for the students in a very nice way. So I am really thankful to all of you, to all head office people, to Mosby, to Nikhil, to everybody, to all seniors, all my colleagues. So and we wish these type of programs continue and our students get enriched, whatever we feel, whatever we know, our whatever experiences we have, we would like to share with our students. So I am very thankful to all of you, especially to you and to Geeta Priya.
Thank you so much, sir. You're always good to listen to your encouraging words. Thank you so much, sir. It's time to introduce our second moderator, Dr. Viraj. Yeah, Dr. Viraj did his BDS from CODS Manipal and his MDS from DAV Dental College, Yamunanagar. He's currently the professor and head of the Department of Dentistry, AIMS, Raipur. His areas of interest is pediatric endodontics and traumatology. He has got various awards and achievements. He's the current associate editor of Indian Journal of Dentistry, assistant editor of JISPPD. He's been the joint treasurer of ISPPD from 2015 to 16. He was the executive member of ISPPD in 2014 to 15 and 2016 to 17. He was the key opinion leader for CAVO, the group of endodontics people from 2014 to 2019. Welcome, Dr. Viraj, to this particular session.
Thank you, Dr. Sharath. And I feel obliged to be a part of this panel. And first of all, I would like to congratulate Dr. Sharath and his full team who has taken this initiative and made it a success. And at the same time, I congratulate and thank ISPPD head office for giving us this opportunity and quick revision to our PG students. Thank you all.
Thank you, Pandit sir, and thank you, Dr. Viraj. Now we'll start the first session. The first speaker for this afternoon session is Dr. Nilesh. So may I now request the moderators to introduce Dr. Nilesh.
Yeah, it is really a great honor for me to introduce. I think is his biodata on the screen. Yeah, is to introduce Dr. Nilesh Rathi. I think personally we have not met before, but as far as his records and whatever lot work he's been doing, I'm introduced to his work right from the very inception. I really appreciate he's done BDS from Sharad Pawar Dental College in Varda, has done MDS from Kotiwal Dental College and Research Center Muradabad. Yeah, he has done PhD also, because quite few number of people had done PhD. Now so many are pursuing this PhD from Sharad Pawar Dental College, Varda. His area of interest is pediatric endodontics, implants in pediatric dentistry, and research in dental implant materials. He has been the guest speaker on pediatric rotary endodontics and Pro AF/AB Gold files and implants in pediatric dentistry for several years. And he's really got a real excellence in mastering this procedure. His achievements are published. He has published more than 50 articles, chapters in books, and has been awarded and has designed a patent and copyrights as well. He has got honors as being the best scientific paper in national conferences. Today, he is presenting on management of crown and crown root fracture. I think I will give this opportunity to Dr. Nilesh Rathi to handle and give his speech today. I mean, give whatever he was going to speak to the students.
Thank you, sir. Thank you very much, sir, for the appreciations. Good afternoon, my dear friends. I am Dr. Nilesh Rathi, Professor and Head in D.Y. Patil Dental College, Pimpri, Pune. Today, I am going to present a presentation on management of crown and crown root fracture. Crown and crown root fracture is seen commonly in clinics, and this is the third most common cause of tooth loss apart from dental caries and periodontal diseases. The prevalence on traumatic dental injuries in common dentition ranges from 1% to 58.6%. And the etiology are non-accidental injuries, road traffic accident, fall and collision, biting on hard substance, sports activities, and violence. But etiology, apart from etiology, predisposing factors also determine the chances of trauma to the teeth. They are class 2 division malocclusion with excessive OJ, environmental determinants, attention deficit hyperactivity disorders, neuromuscular disorders, teeth weakened due to dental caries or hypoplasia, and professional risk. Alice and Davis classification are commonly utilized in India. So,
I think video has stopped. Dr. Sharath? Yeah.
prevalence on traumatic dental injuries in common dentition ranges from 1% to 58.6%. And the etiology are non-accidental injuries, road traffic accident, fall and collision, biting on hard substance, sports activities, and violence. But etiology, apart from etiology, predisposing factors also determine the chances of trauma to the teeth. They are class 2 division malocclusion with excessive OJ, environmental determinants, attention deficit hyperactivity disorders, neuromuscular disorders, teeth weakened due to dental caries or hypoplasia, and professional risk. Ellis and Davis classification are commonly utilized in India. So I will be dealing with only trauma with crown and crown root. So I will be covering class 1, class 2 and class 3, which involves enamel, enamel dentine and enamel dentine and pulp. Then class 4 cavity, where you have got tooth devitalization. Class 6 cavities, root fracture with and without the loss of crown structure. And class 8, that is fracture of crown and mass. AAPD also has given the classification of trauma in 2020, and they have classified under 4 categories, that is uncomplicated crown fracture, complicated crown fracture, uncomplicated crown root fracture, and complicated crown root fracture. So when we compare the uncompleted crown root fracture, it is class 1 and class 2 Ellis and Davis classification. And when we say complicated crown fracture, it means it is Ellis and Davis class 3 fracture, which involves the pulp. When we say uncomplicated crown root fracture, it suggests that it is actually class 6 fracture, but without pulpal exposure. So basically, AAPD has overcome the problem of defining the fracture which is involving both crown and root, because Ellis and Davis suggest only about crown and root, whereas sometimes fracture is combining both crown and root without exposing the pulp. Therefore, in that situation, the AAPD classification of trauma holds true, that is uncomplicated crown root fracture, which can be easily appreciated in this picture, where you can see fracture line extending from crown to dentine but not exposing the pulp. Then the other classification, which is complicated crown root fracture, which is corroborating with class 6 and class 8 of Ellis and Davis classification. So the treatment of class 1 fracture, which is involving only enamel, where if the chip of the enamel is lost and where a small portion is lost, then you don't have to restore, because any restoration requires minimum thickness for its longevity. So in this situation, you will have enamelplasty with 30 or 40 flute carbide burr, followed by topical fluoride application. If the portion is larger, then it can be restored with composite. And if there is chipping off of the fragment of the enamel, then it can be restored easily by reattachment. We reattach the fracture fragment if it is available. In case of class 2, where you have got simple fracture involving enamel and dentine, you finish the margin of the fracture line, which is rag. Then you create a bevel with the help of soft like this mounted on a contraangle handpiece. This soft like this will prepare a bevel, and this bevel will be etched, bonding agent will be applied, and composite will be done. There are 2 different kinds of bevel. One is short bevel using diamond points, but it has got roughened edges. This roughened surface will be visible through the composite restoration also, so it is not preferred. Therefore, we use the infinite bevel, where a bevel is created with the help of soft flex disc, and it is there in only enamel. That means it starts from the dentin enamel junction, it ends in the enamel, and this increases the surface area, improves the bonding, and the most important thing is it helps to match the composite to the original hue of the tooth. So it is helpful for gradual matching of the composite with the tooth substance. The bonding of the composite is always better in enamel as compared to dentine. So we don't prepare dentine, and we want that maximum portion of the composite should be lying with the enamel surface only. Newton Fall has given a technique in which the impression is taken. After impression, the cast is poured, and after pouring the cast, the desired shape of the restoration is prepared on the cast with the help of mock-up wax. This wax is utilized to give desired shape to the tooth and then a putty impression is taken of the cast. When we take the putty impression of the cast, we are already having this putty index, and this putty index will be helpful to have a template for the palatal surface morphology of the tooth. So this composite restoration should not be done in single go. There are 6 different layers for the composite. The first layer should be the palatal layer, and this palatal layer should be created with a darker hue composite. If you use a lighter one, the darkness of the oral cavity will be reflecting outside. This is followed by a darker hue composite, which will be creating a dentinal layer. Dentine will be having reddish brown color, so you can see a reddish brown composite should be used, especially when you say reddish brown pigments, it is there in A shade of composite, especially A3. Then the third step is to create a translucent shade, which will be bluish tint, which will be, if you say the bluish tint, then it will be in Vitapan B shade. It is followed by yellowish color hue of the composite for the enamel, which is later the composite restoration is done with the help of lighter pigment composite, so that the brightness will be imparted to the enamel. We have a tint which will be superficial layer in the incisor edge. If you see here, we have the palatal shelf, and then A3 composite for the bulk of the dentine, which is having carving of mamelons and indentations also. This carving of mamelons and indentation are seen even if you have another layer of enamel, because it is translucent. Here you can see the shape of mamelons and the indentation which is visible, and this is the bulk that is placed over it. This is followed by finishing and carving, because finishing and polishing gives better translucency and reduces the chance of plaque accumulation, and so secondary caries also. The other options are veneer. This veneer can be a thin layer which can be prepared by the direct composite, but it discolors very easily. So lithium disilicic is a material of choice, which gives a good aesthetics, but it is expensive. So laser sintered composite and anamic are used. Anamic is a new resin which gives original translucency, better shade matching, and stability of the hue. The neo technique is inverse injection layering technique. In this, you take the impression of the patient, you pour the cast, then a mock-up wax is used to prepare the desired shape of the prosthesis, and GC has got a Exacclear resin. This Exacclear resin is poured into the cast, and after pouring it, you prepare a template. This template will be utilized to place it intraorally, and after placing it intraorally, GC flowable bulk fill composite is filled through the tip. As you fill it, this template will be acting like a strip crown, and it will be giving the desired shape immediately. In case of fragment reattachment, you will find that the fragments, the original tooth substance is etched, bonding agent is applied to original tooth as well as the fragment. A cavity is created into the fragment so that it provides locking to the composite. The chamfer is prepared at the cavo surface of the original tooth, and flowable composite is flowed to provide attachment of this fragment. This is a post-op picture of fragmentary attachment of flowable composite. Caveri et al. Has suggested that reattachment is giving better prognosis as compared to the composite restoration. Class 3 trauma. In case of Ellis and Davis class 3 trauma, it is involving enamel, dentine, and pulp. So we have to manage both pulp by endodontic treatment and prosthetics for the crown. It depends, the endodontic treatment depends upon the time elapsed of the pulpal exposure and the amount of pulp exposure. The prosthetic treatment depends upon the loss of the crown and the size of the tooth. So when we have pulp exposure, first we have to take a radiograph and we have to ascertain whether the tooth is having open apex or the closed apex. If there is open apex and patient is reporting us within 24 hours and the exposure of the pulp is less than 0.5 mm or 0.5 mm, then we can go with direct pulp capping. Direct pulp capping can be done with the help of new material called as Cervical PT, followed by composite. In case when the patient is reporting us within 48 hours but later than 24 hours and exposure is 0.5 mm, then micropulpotomy and partial pulpotomy is advisable. Partial pulpotomy involves 1.5 mm removal of the coronal portion of the pulp, whereas micropulpotomy involves 1 mm removal of the pulp, which is followed by placement of calcium silicate cements like MTA and biodentine. But if the patient is reporting after 72 hours with the greater exposure of more than 1 mm, then we have to go with either the apexogenesis or the apexification. If the patient is having closed apex and he is reporting us within 24 hours with the exposure of the pulp of less than 0.5 mm, we can go with pulp capping, like that is DPC. But if the patient is reporting us after 72 hours, root canal treatment is advisable. When we talk about the prosthetic treatment for the lost tooth structure, if the crown structure remaining is 2/3, then composite restoration is advisable. But if the crown structure is less than half and it is having oblique fracture line, it is better to go with post and core. Here you can see a different post and core which is called as fiber site, where it has got uniblock, that is post and core are prepared by S-glass fiber and there is no joint. It is a single monoblock unit. It provides better retention. The other alternatives which is advisable when the patient is demanding for aesthetic is endo crown. These endo crowns are prepared by lithium disilicate, and there is a modification of endo crown where you can see that it has got a veneer layer. So when we cover the labial and the lingual surface of the crown with lithium disilicate and it is one piece or it is joined together to the post and the core, which is involving only the pulpal surface or the extension into the canal, it is called as endo crown. This is appreciable here in this diagram where you can see that it is the crown portion, the core and the short post which is engaging the pulpal portion are joined together and they are prepared in one piece. This provides aesthetics as well as retention, and this is called as endo crown because crown is not only engaging the circumferentially to the crown but also engaging the pulpal flow. This is the pre-op picture and this is the post-op picture where you can see that there is endo crown in 1-1 and reattachment in 2-1. Endo crown provides better aesthetics and retention, and it was done after the failure of reattached fragment. Treatment of class 6, that is root fracture with and without loss of crown structure. The fracture of the root can happen in the apical 1/3, middle 1/3 or cervical 1/3. But the treatment depends upon the site of fracture, displacement of the fragment, and associated hard tissue trauma like dental fracture or the missing adjacent tooth. So when you have fracture in the apical 1/3, then there are two ways of treating it. In the first modalities or first option, you will not prepare or remove the pulp of the apical fragment. the pulp will be prepared from the coronal fragment of the root, and this will be obturated. The apical portion of this coronal fragment of the root will be restored with MTA plug. The other option is prepare this canal completely from the apex and fill MTA in the apical fragment as well as the apical fragment of the coronal fragment of the root. The remaining root will be obturated with cutup. Apical third fracture is having best prognosis. The second type is when the root fracture is in the middle 1/3. If it is in the middle 1/3, you can prepare the canal completely and the apical fragment will be obturated with MTA, which will be filled with MTA, and the coronal fragment will be prepared by cut aperture. When you see the fracture in the coronal 1/3, it has got the worst prognosis. Normally, it is indicated for extraction. But there are other treatment modalities which are available and which will be discussed for the management of class 8 fracture. When we want to treat class 8, that is crown and mass trauma, in this case we have got 3 treatment modalities. In this case, you have to go with root canal treatment followed by post-encore so that you can retain the crown. But crown requires a definite margin, gingival finish line, which is not possible in case when there is fracture at the CEJ. So for that we require crown lengthening. So in the crown lengthening we will expose at least 2 mm of the root. 2 mm of the root will be exposed and my finish line of the crown will be placed over it. This will provide a ferrule effect so that it will reduce the chance of fracture of the root. But in case when the patient is having high smile line, it will cause visibility. So the second option suggests is root canal treatment followed by post-encore. So we have root canal treatment followed by post-encore, and then we have orthodontic extrusion of the root. So this root will be extruded orthodontically, and then I will place my crown on the exposed root surface. This will provide me good aesthetics. So it will be a choice, preferred treatment in case when you have a patient with high smile line. The third treatment that is advisable is the implant, because these procedure may fail to provide a longer treatment prognosis. Provisional implant has been proved as a good treatment modality even in growing children. Conclusion: the treatment plan for the rehabilitation of the traumatized tooth should be decided after comparing the various treatment modalities which are depending on the parameters of evidence-based dentistry, particularly for the adolescent. These are the further readings. It is Anderson, J.O. Textbook and Color Atlas of Traumatic Injuries to the Tooth, 5th edition. International Academy of Dental Traumatology Guidelines 2020. And Treatment Planning for Traumatized Tooth by Mitsuhiro and Tsukiboshi. These are the frequently asked questions. So you should stress on endocrowns, about the rehabilitation of Ellis and Device class 8, Ellis and Device class 6, and always keep in mind about the developmental stage of the tooth, because the question may be asked like describe the treatment of Ellis and Device class 3 trauma in a 7-year-old child. So you have to ascertain about the status of the apex. PRF with MTA is also a good option to restore the apex, and it is not necessary to have the MTA plug in the CEJ area only, because if you demand for post and core, the MTA plug can be placed at the junction of middle and apical 1/3, so that you get adequate intracanal space for the placement of the post. Thank you.
Thank you, Dr. Nilesh, for a very nice presentation. And I think we are all open to have question answers at the end of the session. So it was very impressive presentation, and that too very student friendly, and you really try to make it available to the students in a very simpler way. Thank you, Dr. Nilesh. So I shall be introducing our other speaker of the day, Dr. Faisal is a good friend of mine personally to be speaking to you. He is a thorough gentleman, voracious clinician, and has got a very expert eye, exclusively is doing pediatric practice. He has completed his BDS and MDS from RMDCH, Annamalai University. His area of interest are early childhood caries, dental traumatology, pulp and pulpal diseases, role of natural products in prevention of dental disease. It is really a need of our, in this, I think in this government, there is a lot of stress. Whatever indigenous products we are having here, we should try them and use them wherever they can fit for the safety of human beings. So trials are going on. I think the person who starts with it earlier will get better established. So everybody should put their hands on these products and try their level best with all safety measures in mind, and use them in the clinics wherever possible. Currently, he is working as a professor and head, Department of Pediatric and Preventive Dentistry, Kannur Dental College, Kannur, Kerala, India. He will be speaking on management of luxation injuries and avulsion. Over to you, Dr. Faisal. I think it has stopped somewhere.
Sir, there is no audio. Dr. Sharath?
Postgraduate students, warm good afternoon to all of you. I would like to thank the office bearers of ISPPD for giving me an opportunity to present an exam-oriented lecture on management of relaxation injuries and avulsion. So in the next 30 minutes, I will be discussing about the previous question papers which has been asked in various universities in India. Previous question papers shows that essay questions are mainly based on the management of the avulsed teeth and also on the various storage mediums which are available for avulsed teeth. Questions were asked about the old and the new IIDT guidelines comparison, splinting, as well as management of relaxation injuries in children. Always provide a structured answer for the essay questions. There should be an introduction followed by definition, epidemiology. You have to quote about the global studies as well as the Indian studies, type of trauma, pathogenesis, and classification. Classification, you can, if it's an essay, you can write more than one classification. And always make it a point to answer to the specific topic. You don't have to write about everything, about different types of trauma, etc. And answer the relevant studies and protocols. But also, you end up the answer with the references from which you have taken the main parts. I'm sure all of you are thorough with the Ellis classification, but just to recap, Ellis classification was done by Ellis in the year 1960. He classified into 1 to 6 types. Later, Ellis and Davy modified this classification by adding 7 and 8. And later, Hargreaves and Craig modified the Ellis and Davy classification. There is a new classification by WHO, which has been published in the Dental Traumatology Journal last month. Actually, it is a modification of the old WHO classification. Here they have divided into 3 different blocks, and they are given specific numbers for injuries like subluxation and extrusion, which was not there the previous WHO classification. Coming to your answer, there should be a definition. You should write the definition of the avulsion. The question is asked about avulsion. Prevalence, as I have said before, global prevalence as well as the local prevalence has to be written, and the other has to be quoted. You can write about the gender predilection, the age, common age in which the trauma avulsion is mostly seen. Etiology also has to be written by quoting the relevant literature. Now coming to the storage medium, if a question is asked about the storage medium, first you should write about the classification, properties of the storage medium, contents of the storage medium, advantages, disadvantages, milestone studies associated with this, comparative studies, and the end you have to write about the references from where you have taken. Coming to the classification, basic classification is we classify into a natural source and a laboratory prepared. I think all of you know the natural sources of storage, natural storage mediums, that milk, saliva, coconut water, propolis, egg white, mulberry, tap water, etc. Whereas laboratory prepared are Hank's balance solution, salt, normal saline, Viaspan, Eagle solution, etc. etc. According to Anderson et al., he says that pH and osmolality of the storage medium are the important factors just to be considered. They say the optimal cellular growth is reported to occur in osmolality between 290 to 300 milliosmol per kilogram and pH between 2.2 to 7.4. But newer studies shows that a physiological osmolality of 290 to 330 is acceptable. The neutral pH of around 6.6 to 7.8, and the medium should not have a high bacterial content, should have essential nutrients, vitamins, antioxidants, and should not react with the body fluids, and should not produce any antigen antibody reaction, and should reduce the risk of post reimplantation food resorption and ankylosis. Hank's balanced salt solution, HSBS solution, is the widely accepted standard solution for preserving the tooth. It has the ability to preserve and reconstitute the periodontal ligament. It has got a pH of 7 and osmolality of around 270 to 320. But main disadvantage, as all of you know, is expensive and it's not readily available at the accident site. And all of you should be thorough with the contents of the Heinz balance salt solution. Milk is considered to be an ideal solution for keeping the avulsed tooth. It has got a physiological pH. It preserves the viability, mitogenicity, clonogenicity capacity of PDL cells. It has got a low bacterial count and it's very commonly available in our households. Long shelf life whole milk and long shelf life skim milk can maintain the viability of significant number of PDL cells. Studies also show that low fat content is better than the high fat content milk which is available in the market. Studies by Gopal Krishna et al. Shows that coconut water is also an ideal solution. It is biologically pure and sterile, it's rich in amino acids, minerals, and it can store the tooth for a longer period also. It was a comparative study about HBS's milk and the coconut. Study shows that HBS's medium can preserve the tooth up to 72 hours, milk up to 48 hours, and coconut water up to 24 hours. Other mediums are green tea extract, which has got an anti-inflammatory and antibacterial effect. Propolis, which has got anti-inflammatory properties, and it's found to have to enhance the PDL cell viability. Red white studies by Kadami et al. Shows that it has got a physiological pH of around 8.6 and osmolality of 2.8. It has got a high protein content and it can be an ideal tooth saving medium. Saline solution and water both are not good mediums for keeping avulsed tooth. It lacks essential nutrients and study shows that longer storage of saline is harmful. And water also, water has a hypotonic solution, so it is not a good medium to keep the tooth. But if no other medium is available, you can think about keeping the saline or water. Saliva is also not a good medium to keep the avulsed tooth, but can be considered if no other medium is available in the situation. Eagle's medium, yes, it is a good medium to keep the tooth, but expensive and it's not easily available. Custodial, which is an organ transplant solution, is a good medium, but the negative point is it is not easily available. Soy milk has been studied by Gomes et al. And the study shows that it is a good medium to keep the avulsed. Gatorade is nothing but a sports drink which is manufactured by PepsiCo company. It's not a very ideal medium. Contact lens solution may be available at home, but it's not an ideal solution to keep the avulsed tooth because it forms a film over the root surface, which can hamper the attachment of periodontal ligament cells with the alveolar bone. Restral ORS solution, which can be considered as a good storage medium. Patients on serum has been studied before. Casein phosphopeptide, the red mulberry. Probiotics are mainly L-lutein, ATCC 5289, and Bifidum animalis has been studied with the promising results. More studies have to be conducted for the use of probiotics as storage medium. Growth factors can be considered. Ascorbic acid, which increases the alkaline phosphate acid activity, can be considered. Levodopa drug can be considered. But a lot of studies have to be done regarding all these agents. Preparative agents, catalyzed supplementation, condition media, urocolloids. It's also a preservative. Studies have shown that it is an ideal medium, but unfortunately, it's very expensive and not easily available. Emdogaine also has been studied. Antibiotic solutions containing doxycycline has been studied. More studies have to be conducted. Then only we can say it is an ideal medium. So, If essay is asked, you have to enumerate different storage mediums, pros and cons of each and every storage medium has to be written with the relevant statement. This article was taken from an article from Brazil Medical Journal by PedoRare, where they have reviewed the different storage mediums. The study shows that milk, coconut water, propolis, green tea, Viaspan, HPSS, urocolins, MEM solution are said to be excellent mediums. Egg white, isotyl or a solution considered as good, and saline, gastrorate, saline contact lens solution, water, saliva are considered as poor or very poor. This chart shows the comparison of various propulsion mediums. Please go through all these articles so that you can quote the relevant literature where essay has been asked. Now, coming to the answer for the reimplantation of the owl's tooth, your answer should be always based on the guidelines. We have a very set guideline for this, that is the IADT guidelines, which was published in 2020. Your answer should be based on that. And according to it, you have to discuss about the various scenarios. There are 6 different scenarios in which you can do the treatment. And protocols for each scenario has to be written. I'm sure all of you must have gone through this IADT latest guidelines, which is giving guidelines for the fracture and luxations of permanent teeth, avulsion of permanent teeth, and primary teeth injuries. The main point about IADT 2020 guidelines is that it has got the highest level of evidence available now. Whereas the previous guidelines are based on a lot of animal studies, whereas the present guidelines is based on the human reports. And new guidelines encourage long-term follow-up all the trauma conditions. IADT 2020 guidelines, you see that it is classified the treatment procedure for avulsion according to the status of the periodontal ligament cells. The periodontal ligament cells are likely to be more viable if the tooth is reimplanted immediately, that is within 15 minutes. The periodontal ligament cells may be viable but compromised if the extra oral time is less than 60 minutes. Or if the patient comes to you after 1 hour, what happens is the periodontal cells are likely to be non-viable. So there are 6 different treatment scenarios in which you can do the treatment. Patient with the closed apex who has reimplanted the tooth at the site itself. Second scenario can be a closed apex where the patient reports within 60 minutes. And third scenario can be closed apex, the patient reports to you after 60 minutes. Fourth scenario can be a patient with the open apex, self-reimplanted. Fifth scenario can be an open apex where the patient reports within 60 minutes. And the sixth scenario can be an open apex where the patient reports after 60 minutes. Coming to the first scenario, that is a closed apex, and the patient must have reimplanted the teeth at the accident site itself. In this case, the patient comes to you, you just check with the radiograph that tooth is in the right position. If it is in the right position, okay, you can go forward and you can do the splinting, etc. Whereas if the tooth is in the wrong position, you can reposition the teeth and splint the tooth. If there is any gingival laceration or anything, suture it, give systemic antibiotics. The latest guidelines says that amoxicillin is the drug of choice as an antibiotic for in cases of avulsion. And in children always check for the tetanus status of the child. And in 2 weeks after the reimplantation, you have to go for a root canal treatment. It's always advised to keep a root canal medicament for 1 month, like calcium hydroxide, or alternatively, you can think about giving an antibiotic corticosteroid paste and wait for 6 weeks before obturation. Splinting is advised for 2 weeks in cases of avulsion. Most important thing here is you have to review the patient after 4 weeks, 3 months, 6 months, first year, and yearly thereafter for 5 years minimum. Now coming to scenario number 2, where the tooth apex is closed and extra-oral dry time is less than 60 minutes. Here the patient must have brought the tooth in the solution, and you examine the socket, check for any debris or anything over there, irrigate that area completely, remove the coagulum, re-implant the tooth slowly, and stabilize the tooth. And you can do the root canal treatment within 2 weeks. As said before, root canal medicament can be placed like calcium hydroxide for 1 month, or alternatively antibiotic corticosteroid base can be placed for 6 weeks. The radiographic and clinical assessment is the same for all. That is 4 months, 4 weeks, 3 months, 6 months, 1 year, and yearly thereafter. Here in the third scenario, the patient's extraoral time will be more than 60 minutes. That means the periodontal ligament cells may not be viable. But anyway, you have to reimplant the tooth. As said before, just check the socket, irrigate it completely. Take X-ray and see for any alveolar fracture, reimplant the tooth, stabilize the tooth, and give antibiotics as necessary. You have to start the root canal treatment in 2 weeks. Here, what is going to happen invariably is ankylosis will be there, and the tooth can go in for an infraocclusion. In case of infraocclusion more than 1 millimeter, decoronation is advised. Decoronation is nothing but the complete removal of the coronal portion of the crown. So it maintains the bone volume and enables the bone growth in children and facilitates future insertion of the implant in children. Now coming to scenario number 4, where the self-implanted, but the root will be having an open apex. Here also, you just verify the tooth is in the correct position, stabilize the tooth for 2 weeks. You don't have to do a root canal treatment until there is a radiographic or a clinical evidence of pulpal necrosis. To review the patient 4 weeks, 3 months, 6 months, and 1 year, and yearly thereafter. Here the second scenario also, treatment is almost the same. You have to review the patient as I said before, every 4 weeks, 3 months, 6 months, 1 year, and yearly thereafter. In scenario number 6, also, you can reimplant the tooth in the correct position. And if the spontaneous revascularization does not occur, you have to think about, you have to start doing the apexification procedure or pulpal revitalization procedure. Most of the cases, ankylosis will be there. Decoronation may be necessary if there is infraocclusion of around more than 1 millimeter. I'm sure all of you might be having the app in your telephones of APPD reference manual. If you don't have that app in your telephone, just download it from the Play Store. That they have given a chart of acute management of Howell's teeth, where the apex is more than 1 millimeter and less than 1 millimeter. This chart will be very useful to draw in your answer sheets. Now coming to the surface treatment of the tooth, various materials have been advised as a root surface treatment like tetracycline, corticosteroids, alendronate, emdogaine, fluorides, intracanal use of calcitonin, Redamix, etc. But the latest guidelines, 2020 guidelines, states that root surface treatment is not necessary. Now coming to the key points of the IADT latest guidelines. The latest guideline says that the bench RCT, where the RCT is done outside the mouth, is no longer advised. No longer the root surface treatment is advised. No longer the periodontal ligament removal complete is advised. The guidelines also advises to keep a root canal medicament for at least 2 weeks or at least 1 month calcium hydroxide or corticosteroid antibiotic base for 6 weeks. Now coming to the basic difference between the 2012 and the 2020 guidelines, IADT guidelines is regarding the first aid. That is, if the tooth is dirty, previous guidelines say rinse with water or saline. Some guideline says that rinse in the medium which the patient has brought. And previous guidelines says that the tooth can be kept intraorally. The latest guidelines has not recommended to keep the tooth intraorally. And previous guidelines say avoid storage in water. The latest guideline says water is a pure medium, but it can be considered if no other medium is available. Previous guideline says that if the tooth is streamlined in the wrong position by the patient, you can just leave it as such. But latest guidelines says that can reposition the tooth within 48 hours. The 2020 guidelines advises for a 0.4 millimeter wire with composites or a nylon fishing net. Previous guidelines advises for tetracycline. The latest guidelines says amoxicillin or penicillin are the better choices. So in previous guidelines, they say that you have to root canal treatment in 7 to 10 days time. The latest guideline says can go up to 2 weeks. And previous guidelines says that topical antibiotics can be applied. The present guidelines, there is no mention about the topical antibiotics can be applied over. 2012 guidelines advises to remove the non-viable soft tissues with the gauze, but the latest guideline says just remove the soft debris only or loose debris only. The previous guidelines advises to soak the tooth in 2% fluoride medium, which is no longer recommended in the new guideline. And as I've said before, previous guidelines advises to start the canal treatment extraorally, whereas the new guidelines is totally against that. It can be done in 2 weeks' time orally only. So to read more about all these things, you can refer this article in the journal, Dental Traumatology Journal, 2021. The article gives beautifully the charts about the difference between the 2012 and the 2020 IADT. Now coming to splints, when you write the answer about the splints, it should be a definition, purpose, ideal characteristics, classification of splints, advantages of each splints, and duration of each. You know the purpose of the splinting. It is to reposition and stabilization of the traumatic tooth, and it should improve the treatment outcomes. I'm sure all of you be knowing about the ideal requirements of classification. There are general classifications, and but according to our use, it can be basically classified into rigid and the flexible splints. Rigid splints are arch bar splints, complete composite splints, composite with 3 standard wires, which has got a millimeter of around 0.8 is considered as rigid. Wire ligatures, cap splints, acrylic splints, etc. are considered as rigid splints. Whereas composite with 0.4 millimeter wires are considered as semi-rigid, which is advised by the IADT guidelines. Titanium trauma splints, fishing net nylon, fiber splints, all these are semi-rigid. Composites and wire are the most commonly used splint, and it's also advised by the IADT guidelines. They use the 0.4 millimeter wires, which is said to be semi-flexible. And if you see the literature, Prokovic advises to use wire of 0.2 to 0.4 millimeter diameter, Anderson 0.3 millimeter diameter. Trope advises to use wire of 0.15 to 0.30 in diameter. And any wire which is more than 0.4 millimeters is deemed to be a rigid splint. Titanium mesh splints are advised, which is developed by Monarchs. It has got a thickness of around 0.2 millimeters. The disadvantage is not easily available. It's of higher cost also. Fishing line can be used. It has got a thickness of around 0.25 millimeters, and the strength of around 20 pound strength. It allows the physiological movement. IADT guidelines advises this also, and it also says that it's not recommended in children where there are only few permanent need for stabilization of the fiber splints made out of polyethylene or polyethylene fiber meshes can be used. Examples are rebound, fiber splint, elastic. All these can be used. This is strictly acceptable for children, and ease of application is also there. And they don't interfere with the vitality testing when you're doing the vitality test for them. splinted tooth. And there is ease for oral hygiene maintenance also by using the fiber splints. Harsh cross splints are not advised nowadays because it can damage the gingival and the periodontal tissue. Coming to the duration, AIDT guidelines is very clear about it. For subluxation, it's 2 weeks if it is splinted. For extrusion, it's also 2 weeks. Lateral luxation, you have to splint for 4 weeks. Intrusion, 4 weeks. Avulsion is advised for 2 weeks. But if there is a regular bone fracture associated with it, it's advised to keep for more than 4 weeks. And for root fractures, apical root fracture or middle third 4 weeks is advised. Cervical root fracture 4 months, and alveolar fracture is advised to keep for 4 weeks. Should be very careful when you remove a composite splint from the tooth. Should avoid the iatrogenic injury to the enamel. Usually tungsten carbide burrs and soft flex discs are advised. Tungsten carbide burrs like Redfoot ball burr and long-footed flame burrs are advised for removing the composites from the tooth. I advise all of you to go through this article by Canal, the Australian Dental Journal, and also a very good article which shows the history of the dental splits. It's there in one of the university journals, Istanbul University Journal. I advise all of you to go through this article also. Now coming to luxation injuries. Common luxation injuries which you come across are concussion, subluxation, intrusive luxation, extrusive luxation, and lateral luxation. Concussion, as all of you know, is injury to the supporting structures of the tooth without increasing mobility or displacement of the tooth, but with pain on percussion and no gingival bleeding. Here, no treatment is advised. Anticipatory guidance necessary with follow-up of 4 weeks, 6 to 8 weeks, and 1 year is advised according to ILET guidelines. Subluxation, as all of you know, is injury to tooth, supporting structures, loosening, but without clinically or radiographically demonstrable displacement of the tooth is there. There can be a mild bleeding from the gingival surface. Important point is try to follow up the patients. Now coming to the extrusive luxation, here the tooth is partially displaced out of the socket. Old literature says calls it by the name peripheral displacement or partial avulsion of the tooth. Here the tooth is seen as elongated, and occlusal interference may be there. The percussion test may be positive with mild mobility, and radiographical finding shows that the increased PDL space may be there. It is advised to keep a splint for 2 weeks and assessment every 2 weeks, 4 weeks, 6 to 8 weeks, and 6 months, 1 year, and 5 years. Lateral luxation happens in the buccolingual or in the palatal position. Here in this condition, you have to rinse the exposed part of the root saline, apply anesthesia, you reposition the tooth, and flexible splint is advised for 4 weeks. Soft diet is advised, and most importantly, the clinical and the radiographical follow-up has to be there. 2 weeks, 4 weeks, 6 to 8 weeks, 6 months, 1 year, yearly for 5 years. And if the tooth goes for a irreversible damage, can think about root canal treatment. If the root is not completely formed, revascularization, revascularization or apexification. Now coming to the intrusion of the tooth, it is an axial displacement of the tooth. The tooth won't be mobile, and when you percuss the tooth, there will be a metallic sound. And when you take an X-ray and see the PDL space may be absent in the radiographs, it's always advised to take multiple radiographs to find out the extent of the intrusion. The treatment for the intruded tooth according to the guidelines is based on the degree of the intrusion, and also apex of the root is also taken into consideration. If it is an open apex and the degree of intrusion is up to 7 millimeters, can wait for spontaneous re-eruption of the teeth. If it is more than 7 millimeters, it is advised to bring the tooth orthodontically or surgically to the correct position and splint it. If it is up to 3 millimeters in a closed apex tooth, Can wait for 3 weeks for spontaneous re-eruption, which is 3 to 7 millimeters. Advised to bring the tooth orthodontically or surgically, and if it is more than 7 millimeters, advised to bring the tooth to the correct position or by using the surgical methods. The most important thing is you have to follow up the patient clinically and radiographically for 6 weeks, or for 4 weeks, 6 to 8 weeks, 6 months, and yearly thereafter for 5 years. And always there is a risk of external resorption and ankylosis in these patients. Coming to the sequelae of the relaxation injuries, pulp necrosis is one of the most common problems you can encounter in case of relaxation injuries, followed by the pulp canal obliteration, inflammatory root resorption, etc. Coming to the end of this lecture, I advise all of you to go through certain articles regarding each topic. For relaxation injuries, go through these articles by Pendrini et al., Clark et al., Murtala Goswami et al., Darley et al., which is a very important, very interesting article regarding the complications of sequelae of concussion and subluxation. And the article by Risha Doshi et al., which shows the decision tree of relaxation of the traumatized permanently. And also advised to see the 2003 dental traumatology article by Lee et al. For epidemiology, Petty et al., Anderson's articles, Glender's article, Lamar article, and for our point of view, can refer Nitish Tiwari's article, which has been published in Indian Journal of Dental Research in the year 2020. Pathogenesis. Interesting articles are there by Nagarajappa, Lantor, Potens, etc. Avulsions, there are plenty of articles, but invariably all of you should go through these articles. Basically, the Anderson's 1995 articles in dental traumatology journals, just a series of 1, 2, 3, 4 diagnosis and healing complications, factors related to pulpal healing, factors related to growth, and factors related to petrodontal ligament injury. I also advise you to go through the articles by Odoye et al., Australian Dental Journal, year 2012. With this, we have come to the end of this lecture. I have been allotted 30 minutes for this lecture. I have tried to put everything together, important questions together, and I hope these resources will be useful for your forthcoming exams. And I wish you all the best. Do well. Thank you. Thank you, ISBPD.
Thank you, Dr. Faisal. Can you hear me? Hello. Yeah. Thank you, Dr. Faisal. You really gave some new information and some gold standard articles you really supplied, and you gave much of references from those gold standard articles and latest guidelines there too. There's guidelines which are the eternal guidelines which we have to follow, and then now some new additions guidelines. All through your lecture, you really made this possible to the young students. For them, the work to search became a little lesser if they were attentive all through this lecture. Thank you very much.
Welcome, sir.
So can we have Dr. Rupesh? Can you hear me?
Yes.
Yeah, Dr. Rupesh.
Okay.
I have given this responsibility to Dr. Virat, because he's very keen. He knows Dr. Rupesh very well. I think he himself told me that I would like to introduce Dr. Rupesh to the audience.
Yes, sir. Definitely, sir. Just give us a second, sir. 1 second.
Yeah.
Can you see this? Is it visible?
Yeah, it's visible.
Yeah. Over to Dr. Virat.
Yeah. Thank you for the opportunity to introduce Dr. S. Rupesh. He is a professor in Malabar Dental College, Kerala. He completed his BDS from MCOTS, Mangalore, and he did his post-graduation from Rajamuthaiya Dental College, Annamalai University. His area of interest are pediatric endodontics and behavior management. He has been speaker at various local IDA branches and conducting CED programs since 2012. He is training specifically in keto pediatric rotary files and has conducted numerous courses on pediatric rotary endodontics at various state and national conferences and national PG conventions. He has been awarded the best scientific paper in many states and state and national conferences. He's been credited with the best case report of the year published in Kerala Dental Journal several times, and also received the Dr. Sukumar Ajikode Memorial Award for services rendered to Karuna Palliative Care Society in 2013. He also received the most promising office bearer of IDA Kerala State Award in 2017 and has been recognized for the conduct of Dentist Day celebration of IDA Kerala State Branch 2017. Today, he will be presenting on traumatic injuries to the primary dentition. Over to you, Dr. Rupesh.
Good afternoon, everyone. Welcome to the third edition of Virtual PedoRare, the rapid revision for postgraduate students. The topic which I'm going to talk to you about is the traumatic injuries to the primary dentition. We have probably already covered the different aspects of trauma to the permanent dentition. So some things, let me just cover a couple of things. Let me just cover before going into the topic per se. And that is, it is a very desirable thing to get a question in your question paper on dental traumatology, first of all. The reason being, it is mostly you can structure your answer very objectively. The answer does not vary from person to person. It is very easy to explain. And mostly it is like this because it is you have a protocol-based management. You have very clearly set accepted clinical guidelines based on which you can frame your answer. So I'll be talking to you in detail about how you can frame your answers and how you need to quote your studies, etc. So coming to structuring your answer, you should always provide a very structured answer with headings and then subheadings. It should not be one continuous paragraph. And in trauma, you can always be very descriptive with pictographically descriptive. You can draw a lot of diagrams to explain what you intend to do, what you intend to communicate or convey. And third point is you should always have references. Authors' names and years, important studies should always be quoted with with the relevant topics. And because you're with trauma, you have very specific clinical guidelines set down, objective guidelines set down. You should always answer only to the specific topic asked. That will help you from wasting a lot of time, and it will also fetch you more marks. You need to go in depth detail for your viva, because I'll give you examples for each of these points here in my as the presentation progresses. And finally, always avoid irrelevant discussion or topics. When you are asked about a specific topic, please provide a structured framework of answer pertaining to that topic only. And regarding articles, you should always try to quote the recent articles. Make sure you do not miss any milestone studies pertaining to that topic. Always memorize certain important articles which are the key articles related to that particular topic. And management protocols are also very important. And management protocols, you have International Association of Dental Traumatology guidelines, And you have the 2012 guidelines, and now you have the 2020 guidelines, which I'll be talking to you more on. Now, coming to the topic per se, the management of the traumatized primary incisor or traumatic injuries to the primary dentition. Your treatment should be based on 3 factors. First is the remaining lifespan of the primary tooth. It is always determined by how long this tooth is going to be remaining in the oral cavity, and based on that, you'll be deciding whether you should wait and watch, whether you should extract, whether you should do a pulpotomy, etc. The proximity of the root of this traumatized primary tooth to permanent tooth bud. That is the second most important criteria based on which you will decide what treatment you are going to give. And finally, last but not the least, difficulty in gaining child's compliance during treatment. Because here in primary traumatic injuries to the primary dentition, we are talking about children probably less than 6 years of age. Very young children, 2, 3, 4 years of age. So gaining the child's compliance is very important. And so the safe use of sedative agents and general anesthesia is also recommended in the literature. The objectives of trauma management in primary dentition. The primary objective of when you try to manage any trauma is comforting the child and the patient, minimizing or avoid inducing fear and anxiety in the very young children. And then last but not the least, you minimize the risk of damage to the permanent dentition, the permanent tooth buds. Literature says that you have to limit extractions as much as possible for 2 reasons. One is because you are going to lose alveolar bone there, it is not going to grow back. And second, the gubernaculum cord is also going to be missing once you extract the primary teeth. So there will be a delay or bizarre eruptions of the permanent tooth buds. And then finally, you minimize the risk of damage to the permanent tooth by following it up at appropriate intervals. Let's say you have left behind a traumatized primary incisor without doing any treatment. You just follow it up at appropriate intervals as recommended in the literature. Now, any question answer for related to trauma will need to have this pertinent title in your answer sheet. That is epidemiology and etiopathogenesis. For any trauma, even if it is asked specifically, or if asked in total to explain about the entire traumatic injuries to primary teeth, it should have this topic. Now, very briefly, of all the traumatic dental injuries to the teeth, 22.7% are in the primary dentition. And mostly you have traumatic injuries to the primary dentition in the age group of 0 to 6 years, up to 6 years. And here, in this age group, oral injuries account for 18% of all the physical injuries, and the mouth or the oral cavity seems to be the second most common body area to be injured. So you need to know certain numbers when it comes to epidemiology as well. So when you take trauma in general, you have a bimodal peak of distribution of traumatic injuries, of the incidence of traumatic injuries, and the traumatic injuries to the primary dentition peaks at between 2 to 4 years of age. We'll come to that why later. Now, the most common injury in the primary dentition is luxation injury. Now, why is it more vertically placed? They are more upright in the arch. There is a better protection of the lip protection. Because of this, there is a better lip protection for these incisors. Bone, in which the primary dentition is housed, primary tooth is housed, is more pliable and yielding, and it is more resilient. So because of this, the tooth
Sir, video has stopped. It's been paused.
I think there's a problem with the internet connection.
Probably.
Just give us a second.
Right, Chandra?
Sure, sure.
Rupesh, can you hear? Yeah.
Sure, sure.
Sai, I think you are sharing it, Sai. Sai, can you go to that particular this thing?
Yeah, sir. Can you see
thank you.
where I need to start?
Yeah. Rupesh, can you just
Sir, go back.
Go back.
Yeah. 1 second. Yeah. No, yeah. Sai, you have to come back. Dr. Rupesh will tell you where to start.
More.
And then you have to come much ahead. Yeah. He's probably spoken for 10 minutes or something. So
More.
Back.
More. Yeah. Yes. You can play from here.
I think, yeah, here.
So you need to know because your primary insight.
Sir, audio is gone.
Sai, we can't hear this slide.
In which the primary
Audio is available now?
Yeah, now it's fine.
Viable and yielding, and it is more resilient. So because of this, the tooth does not break. The bone heals and the tooth gets luxated. Now, the etiopathogenesis of traumatic injuries is again something which is a must in your answer sheet when asked about any question. When any question is asked about trauma, and you have to know. This is one of the things you have to present when you talk about the etiopathogenesis of trauma, and that is the pathochromic peptide. The pathochromic peptide is nothing but 5 elements which make up the etiopathogenesis of trauma. It contains a predisposing factor, the demographic factors, the elements of the traumatic episode, nature and intent of the trauma, and mechanism of traumatic death agents. In brief about each of these, the predisposing factors you may have anatomic, behavioral, cognitive, medical, and sensory. I will not be going into the detail of these because it is common to both primary and permanent trauma, and it is freely available in most of the textbooks. Now, this is one study which says that which has identified the factors that significantly increase the susceptibility of dental injury, the anatomic susceptibility of a child to dental injury. Post-normal occlusion and overjet effects exceeding 4 mm, a short upper lip, incompetent lips, and a child who is mouth breathing habit. The elements of traumatic episode include energy of impact, resiliency of impacting object, the shape of the impacting object, and direction of the force. Again, I will not be going into the detail of these. You'll find it in most of the textbooks, and it is quite self-explanatory. Now, nature and intent or the etiology and cause of the traumatic injury to the primary injury. So the first is the most important in primary dentition, that is fall and collision. Now, there are 2 terminologies which is important. You need to know that for the Viva. It's called the toddler fall injury and the swing injury. Both occur between 2 to 4 years. Around 2 years is the maximum age at which the toddler fall injury happens, and also the swing injury. Because toddler fall injury is nothing but this is the age. The 2 years is the age when the child is just learning to walk. He or she stumbles, falls, repeatedly falls, and results in traumatic injury to the anterior tooth, which is just erupted. Then you have swing injury, because what happens is children, toddlers, their face is at the level of the swing. So when they push the swing, it goes and then oscillates back and comes and hits the face. So because of this, the swing injury resulting in traumatic dental injury is most common in this age. Sports injuries, regular accidents are not very common in this age group. Now, iatrogenic is again something that happens when when you're working on a tooth and your burr inadvertently slips and contacts tooth, or when you're trying to extract a lower primary molar and you're extraction forceps hits and contacts the jerks on the upper primary central incisor. Now, impalement injuries are also common in this age group, in the toddler, because usually when they have something in their oral cavity, in their mouth, like lollipop or something, and they fall down, the object gets impaled into the soft palate or the palate, or anywhere in the oral cavity, or the cheek, the retromolar area. So these are all common injuries which occur in this age group. Now, another classification with regard to the nature and intent is intentional and unintentional. Now, here you should know the backward child syndrome. Now, these are all topics which you should include in your answer when you write your etiology and pathogenesis and epidemiology. Now, backward child syndrome is something that is seen usually in children, usually under 3 years of age, and it is nothing but a continuous physical abuse from one or both the parents or caregivers. And this is usually done, this physical abuse is usually done to silence a screaming child. And the dentist is often the first person to come across this or diagnose this, because the history of the trauma does not correspond to what you find in the oral cavity of the child. Now, this is again something that needs to be added in order to complete your pathogenesis. Self-inflicted orodontal injuries, these are rare, and examples of self-inflicted orodontal injuries are children having Lay disease or Lesch-Nyhan syndrome, and usually the children have lacerations around the oral and the perioral areas. So again, mechanism of trauma is nothing but direct and indirect. Direct is when a child directly hits somewhere or falls down and has a direct trauma to the teeth and soft tissues. Indirect is a fist hitting the chin and then the lower jaw going and forcefully contacting the upper teeth, resulting in trauma, avulsion, etc. Now, demographic factors also are nothing but the predilection for age, sex, socioeconomic factors, and ethnicity. Now, this is how you frame the diagnosis. You take an essential history, the medical history and the injury history is very important. And you will have very descriptive write-up on this in any textbook. Clinical examination, you will have to do examination. Pulp vitality and sensibility tests as and when indicated as per the treatment protocol laid down by the IADT, the framework laid down by the IADT, International Association of Dental Traumatology Guidelines. Radiographic examination whenever required and whenever periodically required also. You can take intraoral periopical radiographs. Now, sometimes in order to rule out the presence of a foreign object inside the lip or the cheek, you may have to take the radiograph of the soft tissue as well. Now, this is a very good review article on pulp vitality test. It's by an Indian author, Arun and Maitri. You can go through this article. I've included this. So, when you outline the treatment, it should have this three-tier pattern, priority pattern. The first is top priority, which is the head and neck injuries. Second priority is the facial-maxillary, skeleton, and soft tissue. And third priority is the maxillomandibular apparatus and the dentoalveolar counterparts. So this is again common for permanent as well as primary tooth injuries. Now, coming to classification, you have completed the epidemiology, the introduction, the epidemiology, and pathogenesis in your answer. Okay, now you come to the classification. There is only one classification which is exclusive for primary teeth, and that is given by Radanovic in 1956. Ellis and Davey in 1960 has the type 9, class 9 of fracture, which is for the primary teeth, but it does not specify the type of the injury sustained by the primary teeth. Now, this is the classification by Radanovic in 1956. First is fractures of enamel or slightly into the dentin, fractures into the dentin, fractures into the pulp, fractures of the root, minute fractures, and displaced. Okay. Now, these are some of the important articles of studies on epidemiology and it contains epidemiological aspects of both primary as well as permanent dentition. You please go through these and go through these articles. These are again article by Anderson and Lars, the epidemiology of traumatic dental injuries. Now the last two articles are again pertaining to the primary team. The prevalence and etiology of traumatic injuries to anti-aging in 5 to 8-year-olds, and traumatic injuries in the primary team of 4 to 6-year-old school children in India. That's again an Indian study. This again is a very important article which you need to know. It is a comprehensive review article, the World Traumatic Dental Injury Prevalence and Incidence, a meta-analysis on 1 billion living people who have had traumatic dental injuries. Now, these are certain key articles or milestone studies pertaining to the etiopathogenesis and risk factors. So first was about the epidemiology. The studies were about epidemiology, and this is about the etiopathogenesis and risk factors. Now, coming to framing your answer on management, you will have to discuss the answer based on the guidelines given in the guidelines of the treatment framework presented in the International Association of Dental Traumatology 2020 guidelines. So you have your emergency evaluation, you take history, radiographs, emergency instructions, and the management is based on the classification always. Okay. For this you can go by the Rapinovic classification, or you can go by the subtitles of classification which is given in the IADT guidelines. So you give the definition, clinical features, radiographic features, investigations, management, follow-up, and sequelae of trauma to primary dentition. I'll come to it more on it later in the presentation. And I repeat, you should always draw a lot of diagrams for your answers. Now, this is the IADT 2012 guidelines. Now, the International Association of Dental Traumatology 2020 guidelines have come. Now, the difference is that here, if you see the charts, it is quite empty. There's very basic charts are given. But here, in the 2020 guidelines, they are much more descriptive. You should memorize these charts pertaining to each specific type of trauma. I will not be going into the details of each traumatic injury because it will take a lot of time. It is important for you to memorize and go through all the charts. There are 12 charts in all, and they are very ideal for framing your answers in traumatology. Now, sequelae of trauma to primary dentition or the permanent dentition is a major question for you, and there are basically 10 disturbances. The first and the second I have plugged into the first point, that is white or yellow ground discolorations with or without circular enameled hypoplasia, ground eye lacerations, odontomatous malformations, root duplications, vestibular root angulations, lateral root angulation, partial or complete arrest of root formation, sequestration of permanent root germs or dentigerous cysts, and disturbances in eruption. So you need to describe all this in detail, and these are certain key articles pertaining to the sequelae of trauma to primary and permanent dentition, and these 4 are up to 2014, articles up to 2014, and this is an article by our own pedodontist in India, Dr. Nitish Tiwari, who has done an extensive study on research and publication on dental traumatology, and this is an article published in 2018, Long-Term Effects of Traumatic Dental Injuries and Primary Dentition on Permanent Successors, a retrospective study of 596. So please go through this article. Now, your answer should always end with, or rather contain towards end, it should always contain a footnote on trauma prevention. Now, this is a very good review article on, the prevention of dental trauma. Please go through this article. I have included it here in this slide. And your footnote on trauma prevention should always have something on clinical decision support tools. Clinical decision support tools are basically apps. Tooth SOS is an app for the iOS, for the iPhone and Apple devices, which gives a very systematic approach to the patient as to how to go about different trauma if it occurs. This SOS is an app brought out by the International Association of Dental Traumatology, IAD. Then there is a dental trauma guide, which is again a clinical decision support tool, which gives general information as well as specific data about the different trauma to the public. So the long questions which we expect in traumatic injuries to the primary dentition is, you may be asked about primary tooth trauma in toto. So which is what we have discussed so far. And second question, important question, can be a sequelae of primary tooth trauma to the permanent teeth, clinical and radiographic. So you need to give a very structured answer with diagrams, references and details, and always avoid irrelevant discussion. You should need to be objective in your presentation of the answer. So whenever you start your answer, you give an introduction, you define the condition. For the definition also, you cite the author, epidemiology, the global epidemiology, Indian epidemiology, association of this particular trauma with pan-facial trauma, if at all it is such a data is available. The age of predilection in short. Always give cite authors, both studies, pathogenesis, and then come to the detailed management. So the management, I have always already told you this, discuss your management based on the IADP 2020 guidelines. Okay. And coming to prevention of trauma, from prevention of the injury also, you please give more studies and cite authors. Now, trauma awareness, you can actually compare studies and then also make a footnote on clinical decision support tools. I've given an article, a review article on trauma prevention here. Short notes which can be asked from this topic would be intrusive luxation, complications in the primary dentition, and long-term sequelae to primary tooth trauma. Again, your expectation of the answer is for you to be very brief and to the point, be very objective, discuss the specific aspect of tooth trauma only. Do not start from the beginning and come to the end. And you give a very structured diagram and references. You will save a lot of time. Please do not spend time in irrelevant discussions. So intrusive luxation, you have a fantastic chart given by IADP 2020. So you should base your answer based on this framework. Complications of trauma in the primary dentition. You have basically 5 complications, which is given in Anderson in 2011, the 3rd edition of Anderson. You have the Pulp complications pertaining to the color, the radiographic findings of and others. Then you have pulp necrosis, treatment outcomes, the treatment, the pulpotomy, extraction, or whatever it is, the outcomes of such treatment and predictors of pulp necrosis. Pulp obliteration, external root resorption, pulp obliteration and how frequently to monitor them, external root resorption and internal root resorption. So you should base your answer based on this framework. And for Viva, you will have to go into the nitty-gritty of these things. For example, why an adult's primary tooth should not be reimplanted. So the reasons being, the reimplantation may displace the coagulum into the follicle of the permanent incisor and may injure the permanent incisor tooth. But periapical inflammation subsequent to the pulpal necrosis of the reimplanted teeth may cause mineralization disturbances in the permanent teeth. Now, there are 3 case reports where primary tooth traumatized or reverse primary tooth has been reimplanted, and these are those references: Philippi et al. In 97, Gatewood et al. In 95, and Kawashima et al. In 1992. But IADP does not recommend reimplantation of teeth because there is insufficient evidence as on date for reimplanting a primary tooth without causing trauma to the permanent tooth. Again, a few points which I would like to highlight is how would you on plaque control of the traumatized incisor. Brushing is not recommended for 1 week, the traumatized incisor, primary incisor. should clean with it. IEDT recommends cleaning with a soft brush or cotton swab when dipped in 0.1 to 0.2% fluorexidine gluconate. Rinse. Be done twice daily. And contrary to what was believed earlier, there is a lot of emerging evidence for partial or cervical pulpotomy of the traumatized incisor with calcium hydroxide in complicated crown fractures. You should know what are bandage restorations. They are nothing but the dictum is whenever dentin is exposed, cover it with glass ionomer. So glass ionomer here acts as a bandage for the dentin. That is all that is. Now splinting after repositioning. Even if you have mild occlusal interference, it is acceptable. And you splint the tooth in position for 4 weeks. The tooth or the tooth fragment can be splinted in position for 4 weeks. Remember, whenever you have a risk of aspiration, incision, or severe occlusal disturbance, it is indicated to extract the primary tooth. So that brings us to the end of this presentation. Thank you, and all the very best for your exams.
Thank you, Dr. Rupesh. And
Just can I take a moment, please?
yeah.
In fact, just want to highlight a couple of points which I have missed probably due to lack of time I've missed in the presentation. And that is, as Faisal sir had brought out, the differences between the 2012 and the 2020 guidelines. So for the primary dentition, it is just there are just two things. One is that for the 2020 guidelines are more descriptive, whereas in 2012, it is just probably a sentence for the management of each of the trauma. But for 2020, it is quite descriptive, very, very elaborate. The second difference is that for the intrusive and lateral luxation injuries, the 2012 guidelines recommend immediate extraction of the traumatized primary tooth if the direction of displacement of the root is towards a permanent tooth bed. Whereas this is no longer advised in the 2020 guidelines. So I request all the students to please, this could be a Viva question actually, as Faisal sir had aptly pointed out, the 2012 and the 2020 guidelines difference may be a good Viva question. And
it was asked as an essay last time in Kerala.
Yes,
was section. It was asked as an essay.
Yes. For the primary dentition, I request all the students to please go through this particular guidelines regarding the intrusive and lateral luxation of primary teeth. And the second point which I want to highlight, which I failed to mention, is that pulp sensibility test. So you should understand the difference between sensibility test and the pulp vitality test, what these two mean. So both these tests are unreliable in primary teeth, and the International Association of Dental Traumatology guidelines do not recommend pulp sensibility or vitality test for primary teeth. So that's about it. I guess there are so many things more, but then I guess from an exam point of view, in 30 minutes, this is all that we could summarize. So I wish to take this opportunity to thank ISPPD for giving me this opportunity. I'm really humbled by this opportunity to be able to present in the presence of Pandit sir. And thank you, Dr. Virat, for this for the introduction. Thank you.
Thank you, Dr. Rupesh. You have presented in a very simplified manner, and you have systematically told all the postgraduate students how to attempt a question, how to answer. So I think everybody, it's a learning phase. We are also learning, and it's a rapid revision for us also, all the guidelines. Thank you all the speakers. And lastly, we have certain questions in the Q&A. And we can take up Dr. Sharath.
Yes, Dr. Virat, you can go ahead. Any questions are there?
Yeah, we have 3 questions as of now from the Dr. Nilesh part. One was first question is protocols for fragment reattachment and how it should be preserved and for how long we can preserve it before reattachment. It is the name is not written, so I don't an anonymous attendee. So you have to answer this, Dr. Yes, Nilesh. You can say a few words about this.
So, as far as the reattachment of the fragment is concerned, there are 2 important points. The first thing is to sterilize or disinfect the fragment, because when we are attaching the fragment with the help of flowable composite, obviously it is a resin component. So it is expected that whenever a hybrid layer is created after polymerization of resin, it should not be lysed by the bacteria. So there are Candida albicans species which have got property of eating away the hybrid layer of composite, and they are undermining the bonding of that fragment. Therefore, they want that first it should be sterilized in 0.12% chlorhexidine for a minute, and then the fragment should be immediately stored in saline, because saline is a physiologic medium and will prevent the desiccation of the fragment. If the fragment is desiccated, after attachment, you will find there is difference in the shade of the fragment and the original portion of the crown. Therefore, it is advisable to have, as soon as there is a fall, the fragment should be stored in saline and it should be brought in the clinic. It should be sterilized by the dentist by using chlorhexidine, so that we are trying to prevent the degradation of hybrid layer of the flowable composite, and then it is reattached. Now, approximation of the fragment is determined by the close approximation of the margins of the original tooth and the fragment. We require minimum amount of space for flowable composite to hold the fragment. Therefore, we have a preparation of chamfer line at the KO surface margin, and to augment the bonding of the fragmented portion, sometimes a lock is being created in the fragment. So this lock preparation in the fragment will increase the volume of the flowable composite, and it will give extra mechanical retention of the fragment. So this is how we are planning to have fragment reattachment in case of enamel fracture or enamel and dentine fracture.
Thank you, Dr. Nilesh. And I think you have cleared their doubt. On the coming for the second question by Dr. Karishma Jaiswal. Please explain again difference between partial and micropulpotomy.
Yeah, the micropulpotomy is a newer term, sir, and it is only used one of the article. I came across that article which is given by Krasty and Wigner in 2014. So in this article, they suggest that we have to be conservative. Every time we don't have to go with the Swex pulpotomy, that is partial pulpotomy. So if you think that the patient has got trauma and they have reported immediately, so they have advocated the removal of 1 mm of the exposed portion of the pulp. Whereas when we think about Swex pulpotomy, we remove 1.5 to 2 mm of the pulp, of the exposed portion of the pulp. So to conserve or to maintain the larger volume of the pulp and to justify the removal of the pulp, they have suggested that we should have micropulpotomy over Swex pulpotomy. But one thing that they are minding here is, and we usually make mistake while doing pulpotomy, there are two. First thing is, we don't wait for hemostasis and we directly switch over by application of sodium hypochlorite or omeprazole in primary tooth, or application of sodium hypochlorite, or directly getting MTA over the pulp. The primary requisite is to achieve hemostasis just by irrigating it saline. If you are not doing it, then sometimes you may tend to leave infected or inflamed pulp below. Inflamed and infected pulp may bleed. You should allow to bleed so that you can be judicious in removing the infected pulp. So don't ever try to stop bleeding by using medicament like formocasol or directly placing biodentine. First, control the hemo bleeding and then place this medicament. Second thing is, sometimes few articles suggest that you should use sodium hypochlorite for irrigation or chlorhexidine for irrigation of the exposed pulp. But in my experience, I feel you should not use irrigation of sodium hypochlorite because that tend to dissolve the collagen of the pulp and then it is destroying the pulp. Our objective is to maintain the pulp, the healthy pulp. We have to respect their health. Therefore, it is advisable that you should not replenish it with the help of irrigation, but rather keep a cotton pellet which is soaked in sodium hypochlorite 3%, keep it for a minute so that it is disinfected and then remove it. Don't try to dissolve the collagen bundle of the healthy pulp. Don't damage it. So these are the two prerequisites that should be exercised when you are doing procedure.
Yeah, in continuation to this, I think Dr. Rakesh Kumar Chak has asked one question. What are the favorable factors for micropulpotomy?
So micropulpotomy, as I told you, it is indicated in cases when there is open apex and the exposure of the pulp is not greater than 1 mm. It should be lesser than 1 mm. That it is supposedly, it should be 0.5 mm. Bleeding should be arrested. And in that situation, you can go with micropulpotomy. The favorable condition will be that bleeding should be arrested by itself, which is a classical sign that it is not inflamed. And regarding the disinfection, I told you we can have a cotton fillet soaked with sodium hypochlorite. It is good or adequate enough to take care of the health of the pulp. Of course, the material of choice should be either Theracal PT or calcium silicate cement, especially biodentine.
Sir is asking again, what is regarding the time?
Less than 48 hours. So trauma should be occurring less than 48 hours.
Coming to the next question. So can we try management of class 8 fractures, post and core, in the case of cervical root fracture?
As I have covered in my slide, that we have got 3 treatment modalities of preserving or restoring the class 8 fracture. So if I have got time, I can describe it under 2 categories of AAPD classification and the Ellis and Davis classification. Sir, shall I elaborate?
Yeah, there are a couple. You can take 2 minutes if you can finish, because there are a couple of questions people are asking.
Okay. So in case
I think
Ellis and Davis,
I think I can request all the speakers to provide their emails so that specific information can be asked.
Yes, sir. Certainly, sir. We will provide it, sir. So when we come for class 8, that is crown and mass, that means the crown is fractured from the cervical line. Now we don't have anything to hold, because if you want to provide the aesthetics, you require crown. But if you place post and core and then over it you give a crown, then you don't have the margin for placement of crown. And if you don't have margin, obviously the retention and aesthetics is on risk. So there are 2 methods of using the same route. The first method is to have post and core after RCT. And then you can have crown lengthening. In crown lengthening, you cut the portion of the bone from the cervical portion of the bone, you expose 2 mm, and then you have liberty to use that exposed 2 mm of root for having prep, that is final gingival finish line over it. This finish line will give a proper margin for the prosthesis. But when you do it, just imagine when I'm doing bone cutting, my gingival line is getting receded. This receded gingival line will have different zenith of the gingiva. So if the patient is smiling, you will find that on one tooth you will have raised gingiva, on the adjacent tooth you will have depressed gingiva. So it doesn't provide aesthetics. So this technique is only advisable when the patient is having low smile line. That means the cervical line of the crown is not visible. But in situation when the patient is having high smile line, then in that situation you have to bother about the contour of the soft tissue. That is the curvature or the curve line of the gingiva. So in that situation, what you do is you do root canal treatment, followed by you should have the post and core. And after doing this, you try to have orthodontic extrusion of the tooth. So when you have orthodontic extrusion of the tooth, obviously you are not compromising on the gingival zenith, that is the contour of the gingiva, soft tissue, and you are also getting good support from the bone. You are not compromising about the length of the root, which is covered by the bone. So in case when you are having high smile line and the cervical line of the tooth is visible, you should exercise this technique, that is RCT, followed by post and core, and then orthodontic extrusion of that root. When you have exposed 2 mm of the root, then you use that as a ferrule effect, which will prevent the fracture of the root, and it will give optimum aesthetics, which is demanded by the patient. And the third thing, if the patient is wants to have definitive treatment, sometimes they demand for warranty and guarantee, like a product and a commodity. In that situation, directly go with crown. And I have got evidence that even if you go with provisional crown at the age of 12, they are retaining till the age of 20. So provisional crown can be excised and it can be replaced by definitive implants. Provisional implants can be done after the extraction, and it will be followed by the placement of definitive implant.
Yeah. The same in continuation to this question only, can we do fragment reattachment in class 8 fracture and tooth is slightly extruded?
No, you can never do reattachment. It has been tried, and literature suggests, even the APD guidelines 2020 suggest that you should go with rigid splinting for 4 months. Even if you go with rigid splinting of 4 months and you have adhesive between the root fragment and the coronal portion, you can't warranty isolation because of GCF and because of the exposed or frail gingiva. Therefore, it is not advisable to have bonding between the root and the crown, because it is a weak area, and with the slight pressure and movement also, it will fracture.
Right. Thank you, Dr. Nilesh. Sir, Dr. Faisal, sir, there is one question. If a permanent avulsed tooth is got in a completely dry condition after 2 days of avulsion, what is the exact treatment protocol, sir?
The present guidelines, the IADT guidelines advises to reimplant the tooth regardless of the time the patient has come to you. So there is no problem in reimplanting the tooth if the patient comes late also.
Right, sir.
Can I add? Can I just no? Actually, there's one more question asked in YouTube regarding the same thing. Why is extraoral RCT not recommended in the newer guidelines? Initially, it was.
Sir, in this only there is one more question. Why is root treatment not recommended now?
Yeah, it's all based on the
RCT, everything.
Yeah, all these are based on the new evidences which they have got. Like IADT has come out with better evidences in 2020 guidelines. So based on the newer evidences, they have stopped they have advised not to do a bench RCT and root treatments, etc.
Sir, Dr. Rupesh, there is one question, sir. In which cases we can leave the traumatic primary teeth without treating, wait and watch, and review patient by follow-up?
I can't hear you, doctor.
In which cases we can leave the traumatic primary teeth without treating, just wait and watch, and review patient by follow-up?
In general, most of the primary teeth trauma, no treatment is recommended initially. Most of the primary teeth trauma, unless it is severely displaced or it is interfering. Even mild interference to the occlusion is also considered to be, wait and watch, not extraction, according to the 2020 guidelines. Even when there is discoloration in IADT 2020 guidelines, say you don't have to do a root canal treatment, even if there is discoloration, unless it is symptomatic or there is very specific clear signs of infection. Only you have to intervene and go for pulpotomy. Extraction, there is a lot of emphasis on doing no treatment and saving the tooth at the same time in the IADT 2020 guidelines. And much of the treatment, including subluxation and luxation injuries in the primary teeth, it is only wait and watch. Do no treatment unless the symptoms dictate or there is a very clear sign of infection, or when there is a very clear specific indication that it can harm the permanent tooth bud. And these guidelines for each particular specific trauma are given in the guidelines, in the IADT guidelines. I urge each and every postgraduate student to go through these charts. It's very clearly given.
Thank you, Dr. Rupesh. I think last question you have already.
Yes, a couple of questions I've already answered in the chat box.
Yeah, you have sent
regarding plasma-rich protein journal for pulpotomy. Yes.
Yeah, you have sent the journal's name and article name. I think we can conclude the session, Dr. Sharath. All the questions are done. Any questions are there with the postgraduates, they can directly contact in their emails and they can answer.
We will take the email address and we post it to them.
Yeah.
So I would like to thank all the speakers and moderators I'd like to thank all the speakers and moderators for enlightening us on traumatic dental injuries and all the treatment options. I think IADT 2020 has helped us all get a new set of guidelines. And I think all the speakers were really good, and you made sure that every aspect of traumatic dental injuries was touched upon. Thank you so much. May I now request the moderators to kindly present the token of appreciation to our speakers. Firstly, to Dr. Nilesh.
We both from ISPBD and head office, from executive committee members, everybody, all ISPB members, we really feel proud to hand over this token of appreciation to Dr. Nilesh Rathi for his commendable job in speaking on crown and crown root fractures with their management.
Thank you, sir. Thank you very much. Actually, this is my privilege, and I'm a little bit feared also to present this in front of the all learned scholars on this platform.
All the three of you really, you made it so simple and so innovative, and then that was so informative. It was the all new things you have included, having a direct contact with the, direct touch with the previous articles, which we generally consider as gold standards. So you really, in short period of time, I could really feel the hard work you all have done, because Sharad was all the time after everyone that you have to finish it within 30 minutes. You have to finish it, but I really feel that it is really difficult to finish so many huge topics like traumatic injuries to primary dentition is so vast topic and all quite not understood so far by most of the postgraduates. So really nice. I appreciate Sharad and his team who have chosen these topics. Not as the questions, we generally don't get frequent questions in most of these articles, but being a good pediodontist is, I think, the syllabus for this PedoRare 3 has really been worked hard so that good talks have come up. Thank you very much.
Sir, it's all because of trust of ISPPD and Sharad sir and inspiration of your inspiration that we should work hard. Thank you, sir.
Yes, sir. Thank you, sir. Now, can we have a token of appreciation for Dr. Faisal, sir?
Yes, Dr. Faisal, from all of us, from me, from Virat and all ISPD teammates, it is our proud privilege to hand over a certificate of appreciation to you. You are a very versatile, gentle speaker, and we really appreciate all the time your involvement in ISPPD and your own care about children. As and when we have watched you doing things in your practice in your college. Thank you very much.
Thank you very much. Very happy to receive the certificate from you. I also thank the ISPPD for giving me this opportunity. Thank you, Sharad, also for considering me.
Thank you, sir. Thank you, sir. Now to Dr. Rupesh. Have the moderators. Yeah, please do.
See, Rupesh, it is both our projects. I too have worked for some time in Manipal, so Virat was telling me that let me introduce him, because you will take liberty to introducing all the three. Let Manipal person be with me. So he introduced you very nicely, and that introduction has to be very short. But we know that you all have great CVs with you. But due to the paucity of time, we really feel that. But you will excuse us that we could not introduce you fully, all of you. So anyway, it is a token privilege from ISPBD head office and all members here present and all the Pedo family to all the three of you, and especially to you, Rupesh. Thank you very much.
Thank you, sir. Thank you. And last but not the least, I just want to extend a word of appreciation to Dr. Sharath Ashokan, sir, and his team at KSR Dental College, who has worked relentlessly behind the scenes to make this happen. Such a wonderful opportunity. Thank you so much. Thank you.
Thank you, everyone. May I now request all the speakers to share a token of appreciation for our moderators. First to Pandit sir. I think everybody has a personal character.
Thank you.
I became an ISPP member when was the secretary, honorary secretary general at that time. So all of us have our own stories with sir. We are all honored to have you here, sir. Thank you, sir.
Thank you. My pleasure all the time.
Thank you, sir. And now to my friend, Dr. Virat.
Thank you, Dr. Sharath, and the whole team. I thank you and congratulate to do a successful PedoRare revision 3. Thank you.
Now, is it to be pronounced as PedoRare or PedoRare?
Rapid revision.
Rapid revision, sir.
Some people say rare, some people say rare, some people say, but it is rapid revision. And let me really congratulate the person who has designed this certificate. The designing of this certificate is very meticulous and very colorful.
Sir, this person is very much here, sir.
Yeah. whatever you name, this lady is always behind that. So this is a really a great program.
Congratulations,
done by her. Really, we are proud of you, ma'am. So
thank you, ma'am. Thank you.
It was nice designing. Very
Thank you.
Jaipuri
Thank
style
you
or
all
something.
for
Yeah.
Thank you.
Yes, sir.
Thank you.
Yes, sir. Yeah. That brings us to the end of session 6 of day 3. I thank all the moderators and speakers for making it a great session. Thank you so much.
Thank you. Thank you.
Thank you, everyone.
Thank you, sir. Thank you so much.
Sorry, we all beg a leave. Thank you very much. Thank you, and all the best to all of you.
Yes,
And
sir. Yes, sir.
next session tomorrow.
Yes.
Thank you.
Yes, sir. We will all meet tomorrow the sessions.